Hello everyone and welcome to this lecture. Today we'll talk about stainless steel crowns. In stainless steel crowns, there are many important features that people should know when studying and placing these type of crowns on the patients. There are many questions like what is the stainless steel crown, when to use them, and what are they made of. Stainless steel crowns are prefabricated stainless steel crowns that are used with pediatric patients in primary molars and premolars. They are used instead of conventional crowns, conventional restorations, for example, amalgam and composite restorations, as it is very much easier and more predictable to place them than to use a conventional restoration. It is made of stainless steel, chromium, and nickel, so that patients with nickel allergy should not be used with them and they should avoid such crowns. They are usually prefabricated and there are a lot of classification that we'll talk about later. What are they classified to? There are indications on using stainless steel crowns that should be considered. They usually are used in badly broken primary molars, for example, if a tooth has a fracture in the posterior tooth, and they are used only in the posterior tooth for aesthetic reasons. As you can see in this picture, we have the stainless steel crown, and there is after we have done doing the partial pulpotomy, and we use MTA and we have used hard setting cement, and also they are indicated in the to be used after pulp therapy in primary molars. As you can see in these two pictures, down, left, they are used after pulp therapy. And in multi-surface caries, they are also used if there are few walls remaining in the tooth. They also used in severe tooth loss due to erosion. If a tooth is suffering from erosion, then we should use them. And they are used as the temporary coverage during crown preparation and temporary coverage if the patient is too young. In permanent premature teeth and in primary teeth, they are used. In case of primary tooth, we can use them as a temporary coverage. A temporary coverage during crown preparation. In permanent tooth, they can be used in two ways in permanent tooth. If the tooth is not finished its root formation, then we can use them instead of restoration, instead of conventional restoration, as they are less destructive to the tooth. And in case of permanent teeth, when the tooth is receiving a permanent crown, so they can be used as the temporary crown also. In this case, we have a developmental defect called amelogenesis imperfecta. We have used a stainless steel crown to cover the enamel and prevent tooth destruction and tooth necrosis. They also can be used as an abutment with a space maintainer. For the space maintainer, they can be used as an abutment so that the space maintainer hangs to them and does its job. Now let's talk about contraindications of using stainless steel crown. We cannot, of course, use them if the tooth is nearing exfoliation for about 2 years from exfoliation. Therefore, we can use other types of restoration like glass enamel cement as a conventional restoration instead of stainless steel crown. And if there is radiographic pathology or root resorption or tooth mobility, or the tooth is in an aesthetic zone, or if it's partially erupted, therefore we should not use the stainless steel crown. All of these cases, we should rather do extraction. If the tooth is suffering from a pulpal necrotic, then we should remove all caries before proceeding to the stainless steel crown placement. There are two methods of placing the stainless steel crown. One is the conventional method, that is the usual method. If there are a lot of caries and the tooth needs preparation and the patient is compliant and cooperative, therefore we should use conventional methods with a local anesthesia and caries reduction. And if the patient is not compliant, or if the caries are, if we don't suspect that the tooth is suffering from reversible pulpitis, or there is no pathologies and tooth necrosis, therefore we can instead use the Hall technique. The Hall technique is considered to be the golden standard because it provides less time and more comfortable for the patient. Starting with a conventional method, local anesthesia is administered, and then we should then remove the caries. And after removing all the caries and finishing the pulp therapy, if the tooth needs a pulp therapy, we should do an occlusal reduction of 1 millimeter. First we start with the occlusal reduction, then we go to the proximal reduction without producing a ledge at the gingival margin. Without producing a ledge in the gingival margin. Now we understand how to use this method. Let me finish with that subject. As you can see here, we do the proximal reduction, and as you can see also, here is the tooth, and we do the proximal reduction. Okay, and proximal reduction is finished using tapered diamond without producing a ledge on the gingival margin. It's preferable not to produce any ledge, therefore we use a feather-edged finishing line instead of chamfer or shoulder finishing line to prevent chipping and to prevent crown not seating perfectly to the subgingival margin. Later, it's preferable to remove buccal and lingual bulbosities, the bulges that are formed on the buccal and the lingual sides, because these bulges can prevent the crown seating sometimes if they are too large. Sometimes it's not required to do this operation of removing buccal and lingual bulbosities or bulges. Later, we measure the mesiodistal length only in aiding the crown selection. We measure it with the periodontal probe, for example, or with a small ruler, a divider, it's also called, to measure the mesiodistal dimension. With any other device we can use to measure the mesiodistal. Also, we can use the methods of trial and error in seating the different types of crowns to see which one seats perfectly to the tooth. In the crown selection, here, we can use this method. Later, check the height of the occlusion. We check the height of the occlusion, of course. It's important to take 1.5 millimeter so that the crown can fit. Check the height of occlusion, and minor prematurity is not a problem. There is a prematurity in the biting, so that's fine because a primary tooth can adapt very well to the new restorative crown. If extensive blanching of surrounding tooth tissue or overextended, then we cannot trim the margin of the crown. Now this point is very important because, as you can see, sometimes the crown is overextended to the margin. Therefore, we can, using a scalpel or some kind of instrument, any kind of instrument, to make a point here and on the crown, and then we can use it, take the crown out and trim it to the appropriate margin. If the crown goes a little bit of 1 millimeter subgingivally, then that is fine and provides good seal. But if it does more than that, then there should be more there should be a reduction to prevent the crown from impeding and impinging on the subgingival tissue that could cause blanching on the gingiva. The cements that are used in the case of stainless steel crown can be any kind of cement, zinc phosphate, zinc polycarboxylate, but preferably as a GIC, glass ionomer cement, to cement the crown. The whole technique, also called biological technique, it's another method of placing the stainless steel crown. It is more preferable and could be the golden standard for primary molars. This technique, there are many advantages, as we can say, as we know, that there are reduced time placing and reduced discomfort. But the disadvantage can be that there would be caries remaining above the pulp that could cause problem in the future, and we cannot use it if we suspect that the caries should be removed, and if they stay, there might be pulpitis or reversible pulpitis or pulp necrotic or any kind of pathology in the pulp. In this technique, we don't have to do any conventional preparation or caries removal. There won't even be any local anesthesia. It's so simple and quick and easy. We use separators to separate and give distance for the tooth for 2 days to a week. After 2 days to a week, the patient come back and we remove the orthodontic separators. Then we try in the crowns to fit and seal the caries from the surrounding environment. We have to also check and do an X-ray to check that the primary molar is free of any pulpal or periradicular or periapical pathology. Then we select the size and fill it with zinc oxide with the GIC and placing it on the tooth. We advise the child that the crown can feel a little bit pressure, and advise him to bite down and clear any excess with the use of a dental floss and a probe or an explorer. Here, as you can see in this picture, after we try here in this picture to seat the crown from the lingual, then the buccal direction, as it could be harder to seat it from the buccal than lingual. Then we put it on the tooth and we advise the patient to bite down on the crown, and it's preferable to use some kind of a gauze here to prevent the airways and to prevent the patient from aspirating the crown, prevent it from falling down into his airway or stomach. Usually, the crown can be felt and seen to be in the premature occlusion, but as long as that's not gross enough and to an excessive amount, the occlusion would adjust itself and returns back to its normal. In the whole technique, there are two advantages, two novel two novel ways, or the whole technique is novel in two ways. The first is that the stainless steel crown is cemented without preparation or local anesthesia. That's the first thing. We don't need any local anesthesia or tooth preparation. Then there is not even caries removal, but the seating of the stainless steel crown and the cement isolates the tooth from the rest of the mouth, isolates the caries and prevents its development, arresting it. There are many types of stainless steel crown. There are the untrimmed, trimmed, and pre-contoured. Pre-trimmed, and there are untrimmed. This one, untrimmed. Then the pre-trimmed and the pre-contoured. The best and perfect one is the last one, the pre-contoured, because it will come pre-trimmed and pre-contoured, making it easy to fit to the patient's crown and prepared tooth. These are the kits that are used in the preparation in the crown, stainless steel crown. This one is the one we use in the clinic, and this one is another one that can be seen here. All the numbers and on the teeth are marked. The success rate, there are a number of studies of the conventional and the whole technique that's indicating a more longevity in the primer tooth for the stainless steel crowns. They are more advantageous and easier to place and less discomfort to the patient and more favorable. Especially there are studies on the whole technique indicating a favorable result, affecting and creating an effective periodontal seal. After the operation, we can determine if the crown was seated post-operative. After we have done the pre-operative evaluation, now we go to the post-operative evaluation. In the pre-operative evaluation, we have studied that the tooth should be non-mobile, and it is selected for the operation and whether the tooth is indicated or non-indicated for the preparation. Now, after that, we do the post-operative evaluation. We see it from the clinical and the radiographic evaluation. The clinical evaluation, you can see that the crown is well seated to the gingival margin. There is a festooning. That is festooning means the way that the crown margins are adapted to the gingiva. As you can see, they are well adapted and they are not impinging on the gingiva. 1 millimeter, about 1 millimeter subgingivally would be a good isolation and seal of the crown and of the tooth. In this photo, we can see here that the crown preparation was perfect and the crown is radiographically well adapted and seated. In this radiograph, we can see that's also well adapted and seated. But here we can see that this point is correctly seated, but in this it's not very well seated, as there are a little bit of under preparation, and the crown is a little bit smaller than the tooth. Therefore, there are ways to adapt the crown to the tooth, and these called the crown modification. In the first one, we use a crown scissor to trim the crown to a better location. There are also contouring pliers, a ball and socket plier used to contour the tooth much better. And also we can use a crimping plier to adapt the tooth in the gingival area. We can also use burrs to smooth the crown. We can, from the marginal area here, we can use a burr to smooth this area around the gingiva. We can also use pliers to squeeze the crown mesiodistally to adapt it much better, to have a much better fit to the prepared tooth. This is a scientific study that I have looked and seen that the whole technique, a randomized controlled study, a method of managing caries management in the general dental practice. This is a study of the crown. If you want to look at it and see how the crown was selected, and this study shows a favorable impact of the stainless steel crown to the conventional and other methods like amalgam and composite material. The conclusion of this study is that the whole technique was assisted by the general dental practitioners as causing significantly less discomfort compared with conventional restorations technique. Quick review after we have finished and seen everything about stainless steel crown, how it's placed, what it's used for. There are also many other information that if you want, we can answer it another time. We have studied and understand the stainless steel crowns and their indications, contraindications, methods of placement, the whole technique and the conventional technique. We have seen what is the success rate of the stainless steel crown and the post-operative and pre-operative evaluation. And we have seen a scientific study on the stainless steel crown. If you have any question, please write it down and I will try to answer it as fast as possible. And there are sources. These are the sources that I have concluded my PowerPoints from, so please visit these sources and take a look for yourself if you want to determine whether or not to use this method in your practice or not. Thank you for listening to this lecture, and I hope you had a good time listening to it.